A patient complains of headache, nausea, and is drowsy after a head injury. Is this significant? Why? What would you do next? Yes. Possible raised intracranial pressure and danger of reduced cerebral perfusion pressure and cerebral herniation. Monroe-Kelly doctrine of fixed intracranial space. History and physical examination. GCS. Intubate early. If clinical picture suggests deterioration to 8/15 or less. Check for papilloedema. Full neurological examination. CT head. What might cause raised increased intracranial pressure, ICP? Intracranial bleeding, brain tumors, cerebral edema, hydrocephalus. Name some secondary causes of brain injury. Primary brain injury takes place when the primary insult occurs and is considered irreversible. Secondary brain injury results from processes initiated by the primary insult that occur sometime later and that may be prevented or ameliorated. Management of head injury aims to prevent secondary brain injury. Causes of secondary brain injury include raised intracranial pressure, vasospasm, hypoxia, hypotension, hypercarbia, hyperpyrexia, hyponatremia, and other electrolyte disturbances, hyperglycemia, hypoglycemia, anemia, sepsis, raised venous pressure, seizures. What do you understand by the Monroe-Kelly hypothesis, or doctrine? This describes the pressure-volume relationship between intracranial pressure, CSF, blood, and brain. The hypothesis states that the cranial compartment is incompressible and therefore the volume inside the cranium is fixed. Its constituents, brain, blood, CSF, create an equilibrium such that any increase in volume of one must be compensated by a decrease in volume of another. For example, an increase in lesion volume, e.g. intracerebral hemorrhage or tumor, will be compensated for by a downward displacement of CSF and venous blood. These compensatory mechanisms are able to maintain normal ICP for any change in volume less than approximately 100 to 120 milliliters. When this mechanism has no further reserve capacity, the intracranial pressure increases rapidly. The result is hypoperfusion and herniation. How can the ICP be reduced? Patient positioning. Nursing the patient head up. Avoid obstruction of venous drainage from the head, making sure C-spine immobilization collar is not too tight. Adjusting PaCO2 by manipulating ventilation. Adjusts intracranial vessel, vasoconstriction, wash, dilatation, fluid balance, e.g. diuretics, mannitol, etc. Sedation, e.g. barbiturates, with or without muscle relaxants. Steroids, e.g. dexamethasone, can reduce cerebral edema around tumors. Induced hypothermia and anticonvulsants. Lower metabolic demands of brain tissue. Tapping off cerebrospinal fluid via a ventricular catheter. Emergency surgical evacuation of any hematoma causing mass effect. Burr holes, craniotomy, decompressive craniectomy. What emergency neurosurgical procedures may be undertaken for head injury? Burr hole, frontal, parietal, temporal, occipital, craniotomy or craniectomy. Ventricular tap. Elevation of compound depressed skull fracture. What are the indications for CT in head injuries? Falling GCS. Persisting neurological signs, headache or vomiting post-resuscitation. Clinical suspicion of a fracture of the skull base. CSF rhinorrhea, otorrhea, battle sign. Subconjunctival hemorrhage with no ascertainable posterior border. Suspected penetrating head injury. Post-traumatic seizures. Patient has a coagulopathy, e.g. on warfarin. The patient is difficult to fully assess, e.g. alcohol intoxication. What are the intracranial abnormalities that indicate urgent neurosurgical management? High or mixed density intracranial lesion, size and site. Midline shift. Obliteration of third ventricle basal cisterns. Contralateral ventricular dilatation. Intracranial air. Subarachnoid or intraventricular hemorrhage. For more MRCS Part B resources, please visit MRCSBites.com.